good morning, distinguished clients and their spouses, the anchor persons of today's antenatal class session, distinguished head of the Department of Obstetrics and Gynecology and our heads of departments present here, members of Ebony Waves, and wish you another happy 65th anniversary as a nation. I'm a Nigerian, born in Nigeria. I schooled in Nigeria, and I practice in Nigeria. Celebrate the greatness of my nation. The lecture of today, titled Antenatal Care as a Tool of Preventive Medicine. I first delivered this lecture sometime in November 2004. And so it's a topic dear to our hearts here, because I know that the power, the might and development of a nation, the greatness of a nation is not measured by the number of tall buildings that adorn its skylines. It's not measured by the length of its presidential convoy, nor by the number of the ministerial aides. The might and the greatness of a nation measured by two broad categories. One is economics. And for those of you here who are captains of industry, you know we use our gross domestic product per capita and our gross national income to measure how great a nation is. But there is a second category that has to do with social parameters and indicators such as the life expectancy, our infant mortality rate. In other words, how many children are born per 1,000 kids, how many survive beyond 1 year. The greatness of a nation is measured by its maternal mortality ratio and the life and the literacy rate. So today we're going to be dealing with one that has to do with maternal mortality. A nation that loses its infants is not likely going to go so far, because we must bequeath legacies to our younger ones. And similarly, a nation that loses its mothers is not likely going to be great, because it is the women that oil the wheel of fellowship. So the objectives of today's antenatal class session is to raise awareness on the value of antenatal care in the elimination of pregnancy-related deaths. We are of the considered opinion in this organization that the idiom, the saying that what's going to be is going to be, it's not true. There are many deaths that are needless. The objective of today's antenatal class session is to educate our clients on what to expect at each antenatal visit to the DIF Medical Center. Is to enlighten our clients on their roles and that of their families in reducing the chances of maternal morbidity and mortality. I'm going to attempt to use this session to address traditional nuances. I will attempt to dismantle cultural practices like hot water bath after delivery, deal with obnoxious belief systems, and deliver our clients from the trappings or backgrounds that has held our women hostage and deprived them of enjoying the beauty of modern obstetric practice. It's all about prevention. Prevention is better and cheaper than cure. I want you all to know that the pregnant woman is a fourth person. She's not a male. She's not a female. She's not a child either. She's a different person entirely. The reason is because the pregnant woman carries an additional organ called the placenta, which men and other females don't have. It is the placenta and the hormones that it secretes, 25 of them, that is responsible for the changes that take place in women, and it is the organ that is responsible for the behaviors of the pregnant woman. The pregnant woman is a fourth person because her blood pressure behaves differently, her kidneys function differently, her immune system is compromised. Pregnancy is a diabetogenic state. Pregnancy is a thromboembolic phenomenon. What I mean is this. Every pregnant woman sitting here, you carry the risk that simply because you are pregnant, you can have a distorted or a disturbed glucose tolerance that may lead to outright diabetes mellitus. Pregnancy is a thromboembolic phenomenon because in preparation, it takes 9 months for the body to prepare you for pregnancy, because on the day of delivery, we're going to be removing your placenta, and after the removal of the placenta, systems have been put in place to make sure you don't bleed to death. That system has to be carefully monitored, or else it can swing you to the other side. Pregnancy is a physiologic phenomenon. It is God ordained that we should multiply and reproduce, but it has adaptive changes. The pregnant woman is still pregnant until she's 6 weeks post-delivery. That is why most women who carry their first pregnancies, if you're going to see the maternal mortality or death, it will be occurring around the 14th or the 15th day post-delivery, when everybody had let down their guards. No two pregnancies are the same. This is important, particularly for those of you who have had deliveries before, and you begin to wonder, what is the need coming to antenatal? I've done it before, I can do it again. It doesn't work that way. Antenatal care is oftentimes the first exposure an individual makes with the medical community. That may be the first time some people will be knowing their blood group and their rhesus factor. There are people who are going to be knowing that they are AB negative or O negative for the first time during antenatal. And yet, for one reason or the other, you may have exposed your blood to positive ones. And you are O negative. Now you are pregnant. Antenatal care is often the first time you may be knowing your HB genotype. Some people get to know for the first time that they are not AA, neither are they AS or SS, but they are AC. Some get to know their blood pressure, their blood sugar, their height and weight for the first time. Preventive medicine, therefore, is the mitigation of disease, either by preventing the occurrence of a disease or by halting a disease and averting resulting complications after its onset. You must know that in this day and age, no woman in 2025 should give up her life because she's going to give birth to a life. The fact that you are pregnant should swing you between life and not between life and death. It is my hope that after this lecture, we should be able to say the last maternal mortality in the land of my birth occurred yesterday. There should be no other way. Pregnancy must never swing any woman's life between life and death. Rather, the pendulum should swing between life and life and between life and celebration. I'm sure you are aware that many nations are closing their borders and restricting citizenship by birth. Therefore, we have no choice but to develop our system so that we can deliver expectations and attain the level of maternal care that has distinguished the practice of medicine in some other nations I will make mention this morning. Antenatal care is a tool of preventive medicine. What is a tool? We all know, each of us should be able to define a tool. A tool is a device, it's an equipment or strategy that you use to carry out a particular function or accomplish a particular task. Many things are important to make a woman carry pregnancy successful. If I'm going to place a premium, they're all important, but I'll place a premium on information, education, enlightenment. A tool is anything that can help you to do something you want to do. If this nation wants to reduce maternal mortality rate, they don't have a choice but to promote and project antenatal care practice. No amount of mosques or churches you build can take the place of knowledge, because ignorance is the bane, is the reason for many maternal mortalities. So let's look at the history of antenatal care. Before 1900, maternal mortality and morbidity in the United States and the Western nation was the same like it is in Nigeria. After all, we breathe the same air. The song we just took said that Nigeria have the prettiest women in this world. And I agree. If you doubt it, you need to take a look at my wife. And then you understand that that song has meaning. But the nation of the United States first noticed that maternal mortality was sniffing life out of their citizens, and it was closely followed by infant mortality rate. And they began to put in place a structure, an organized system of taking women through this thing called antenatal care, education, coming for visits, see your doctor. Make sure you see your doctor at least 4 times. And this, the United Kingdom quickly joined. 1900, that quickly reduced fetal mortality by 40%. Quickly. Nigeria did not join, possibly because of the value maybe we place on human life, until Professor John Lawson, practicing at the University College Hospital, Ibadan, and Professor David Stewart, who was the pioneer of the College of Medicine in Jamaica. These were 2 British-born obstetricians and gynecologists, joined heads together and said Nigerians and the Caribbeans must start antenatal. And that was in the late 50s. In the Federal Republic of Nigeria, I doubt if you can become an obstetrician and gynecologist without reading the textbook written by Lawson and Stewart titled Tropical Obstetrics and Gynecology. By the model of Professor John Lawson and David Stewart, which they modeled quickly after what was happening in the United States and in London. We had 4 visits of 4 contacts. It was recommended that every pregnant woman should have 4 visits of 4 contacts with a healthcare provider during pregnancy. The first visit was referred to as a booking appointment, during which pregnancy is confirmed, preliminary health checks are carried out, so the first consultation was usually longer. But in 2002, the World Health Organization introduced what is called focused antenatal care, the FANC, to replace the traditional 4 model care. The attempt, the reason, was to try to increase the number of times people, pregnant women, have contacts with healthcare providers. Many nations, 76 nations, signed into it in 2002. The land of my birth signed in 2006. The World Health Organization realized that in spite of this focused antenatal care, maternal morbidity and mortality did not reduce significantly in the African continent. They gathered again in 2016. The World Health Organization updated its guidelines, recommending at least 8 antenatal visits throughout pregnancy if we must improve maternal and fetal outcome. In spite of all these efforts by the World Health Organization, it is sad to declare that 38% of Nigerians do not pursue any form of care during pregnancy. Distinguished students, there are 27 neonatal deaths per 1,000 live births. Very sad that Nigeria is the maternal death capital of this whole world. In other words, Nigeria is the worst country in the world to give birth. This is in spite of our endowments. What is maternal mortality? Maternal mortality is the death of a woman from causes related to or aggravated by pregnancy and childbirth, occurring during pregnancy or within 42 days of delivery, excluding accidents. So the maternal mortality ratio measures the number of these deaths per 100,000 live births. Across the world, bleeding during pregnancy, delivery, and after delivery is the leading cause of maternal mortality, followed quickly by complications of hypertensive disorders of pregnancy, infection, delivery complications. Fortunately, these factors are preventable and treatable. Let us look at this table. If you take any textbook, any scientific journal, and ask maternal mortality ratio, there are 195 countries in the world. The first country that will jump up is the Federal Republic of Nigeria, where we lose 993 women per 100,000 live births. When I mean 993, I mean the ones that come to the hospital. What about the ones that were born in my village and in your village that does not have a record? The next country is Chad, 748. The next is South Sudan, 692. Country number 4, don't give birth there, is the Central African Republic. 692 deaths per 100 live births. The 7th country is Afghanistan. The 48th country is Pakistan. The 74th country is India, that loses 80 per 100,000 live births. At the time I was in the medical school and doing obstetrics and gynecology posting 42 years ago, we had a mnemonic for knowing the countries that you never give birth. We used the acronym called PAIN, P-A-I-N, where P stands for Pakistan, A stands for Afghanistan, I stands for India, and N stands for Nigeria. 42 years down the line, Pakistan and India have taken their names from that ignoble list. Country number 130 is the United States of America, where we have 17 per 100,000 live birth. I have had several of my own patients who died in the United States, so I know these figures are correct. The one that surprised me is the war-torn Gaza Strip. It's still safer to deliver in Gaza than to deliver in Nigeria. It's number 133. What about the war-torn Ukraine? They lose 15 for every 100,000 live births. The country that most of my people now run to is called Canada. Canada loses 12 women for every 100,000 live births, followed by the United Kingdom, 9 per 100,000 live births. The tiny nation of Finland will lose 8 per 100,000. United Arab Emirates will lose 3 per 100,000. Belarus, 2 per 100,000. The nation, the Scandinavian nation of Norway, with 5.6 million citizens, will lose only 1 per 100,000 live births. The Cook's Island, that borders New Zealand and in the Oceania, understandably having only 28,000 citizens, they will lose nobody in 1 year. Ebony Waves, please come take this song with me. Which Way, Nigeria? Ebony Waves. For every 1 maternal death in Nigeria, there are 37 morbidities. When I mean morbidities, I'm talking about vesicovaginal fistula, intractable puerperal infection that may even lead to a total abdominal hysterectomy. We're talking about either the Sheehan's or the Simon's disease, where you will no longer menstruate again simply because you give birth. Let's not even talk about menstruation, talking about breastfeeding. For every 1 maternal death in Nigeria, there are 37 morbidities. Women who by reason of their birth cannot breastfeed again, or would have lost 37% of their brain power because of 1 incidence of eclampsia. What did the nation of Norway do differently? The women in Norway, in Belarus, in Cook's Island are not better. We breathe the same air and possibly we eat the same food, and I dare to say that our women are prettier because I've had the unique privilege of crisscrossing virtually the continents of this world. So I've seen things What did they do differently? If Nigeria must change its narrative, if hospitals must change this report, we must pay a visit to Norway, we must pay a visit to Cook's Island and find out what tool did they use. I know the tool they used. It's antenatal care. I dare to say that by the grace of God, give me the same 100,000 women. Just give me 100,000 women who have the resources to pay my bills and attend antenatal care religiously. I will deliver the same results and the same reports of Norway. I will. Late Sir Sonny Okosun, born 1947, died in 2008 at the age of 61 from colon cancer. In 1984, barely 24 years after Nigeria's independence, released a song titled, Which Way, Nigeria. 41 years have passed. Nigeria's mortality ratio has not changed significantly. We are here today to provide solution. Whatever took place in Norway can take place here. Ebony Waves. So it's a call to action. And this is what we have done here. And that's what gives us our joy and our pride. That husbands and families can leave their wives with us. And we can tell them, go buy your baby things. We will deliver your expectations and we'll give a fulfillment to promise. What is the aim and purpose of antenatal care? Thank you, Bonnie Waves. The purpose of antenatal care is to have a healthy mother, a mother who should be able to reproduce her kind again, to have a healthy baby or babies who can fulfill his or her God-given potentials, to have a satisfied father, and have a happy family. Every wanted and unwanted pregnancy should result in the delivery of a healthy baby without impairing the mother's health. So, when you come to antenatal care at the DIF Medical Center, these are our objectives. Each time I see you, each time Dr. Barrow sees you, each time Dr. Ifedo Koko sees you at the antenatal, this is our objective. One, to promote and maintain the physical, mental, and social well-being of mother and baby by providing education on nutrition, personal hygiene, and the birthing process. Because health is not just the absence of disease, it is a state of a good physical, mental, and social well-being. When you come to antenatal care, we educate our pregnant women on the alarm bells. Nothing happens by chance. No woman dies by mistake. Distinguished students, listen to me. This is what I have practiced. I'm 40 years post-graduation. I know what I'm saying. I've been in obstetrics and gynecological practice my lifetime. No woman dies by mistake, by chance. There's always an alarm bell that you did not take note of. Why will you not take note of it? So let me then equip you. If you drive a good car, if the engine oil is low, or the pressure, the tire gauge is low, the dashboard will show an alarm bell. What most mechanics do in Nigeria, they'll disconnect the wire so that you won't hear the alarm again. Because they believe that ignorance is bliss. In antenatal, ignorance. In pregnancy, ignorance is death. So what are the kind of alarm bells? Like bleeding from any orifice. Oh, a woman is bleeding from the vagina. She's bleeding from the nose. She's bleeding from the anus. A woman can lose 1,000 mils of blood within 1 hour just bleeding from the nose. I'm telling you. Hyperemesis gravidarum, excessive vomiting in pregnancy. Oh, no, you see, there's no problem. There's problem. Liquid drainage. Suddenly you see fluid draining out from your vagina. You want to consider it as a normal vaginal discharge, but when it becomes profuse, it has odor and it has color. When you have persistent headache, yes, headache and pregnancy, they are first-degree cousins. But when you mix headache with leg swelling and add protein in urine, you are in a different ball game entirely. When you have fever that is not abating, when you have lower abdominal cramps, there are alarm bells that something sinister is happening behind the scene. That's why you're here. It's called preventive medicine. Knowledge is power. The objectives of antenatal care each time you come is to detect and manage complications during pregnancy, whether it is medical, surgical, or obstetric. So please, whenever you come to antenatal and we ask you, do you have any problem, tell us. If you have problem in your toe, pain in your toe, tell us I have toe pain. If you have pain in your ankle, I have ankle pain. I have headache. I didn't sleep yesterday. No symptom is too small to report, please. That's why you paid, so that we can care for you. We use the objective of antenatal care, we use it to develop birth preparedness and complication readiness plan. Oh, common sense tells me that if I want to take a woman who has had a previous myomectomy to go and do a cesarean section, common sense tells me that I should be prepared for battle. You don't joke. You don't sleep. You plan it. This is how I'm going to enter this woman. If I meet this challenge, this is what I'm going to do. You rehearse it before you go for surgery. That's how it is. That is just how to reduce mortality. You don't wake up from the right side of the bed and say you're going to do surgery on a woman who has had some surgical histories. So you develop your birth preparedness. You help prepare the mother to breastfeed successfully. There are women who cannot breastfeed. There are women that breastfeeding is contraindicated, but there are women who want to breastfeed, but they cannot because their nipples are inverted. How come you saw a woman from beginning to the end of pregnancy and you never looked at the nipple to see whether this nipple can function? So it is our job to make sure you experience a normal puerperium and take good care of the child physically, psychologically, and socially. Each time we see you, we promise that we will properly detect and treat pregnancy-related complications. Hey, no woman on earth should convulse because she's pregnant. Any woman that convulses because she's pregnant is a failure of the medical system that took care of that woman. QED, that's what it is. But how would we know unless you tell us? We must prevent, we will prevent, and we shall prevent and manage concurrent diseases through an integrated service delivery. We will provide prophylaxis against malaria, tetanus, and ISO immunization. Somebody will say, is it not malaria? Malaria can kill a pregnant woman. This is because a woman carrying pregnancy for the first time, at the 28th week of pregnancy, your immunity is so low that malaria can snuff life out of you. So we need to begin to make sure we reduce the severity of the malaria by giving you prophylaxis. We have to discuss provision of post-delivery contraceptive strategies, and then we will categorize every woman that comes in for our services into high-risk and low-risk groups. These are the variables. Students, as you are listening to me, put yourself, just be taking note. Am I high-risk or am I a low-risk patient? There is no middle. Age. Any woman carrying pregnancy for the first time before the age of 18 is called teenage pregnancy. I have a master's degree in public administration from the University of Maiduguri. I did my thesis and dissertation on the social and medical complications of teenage pregnancy amongst 10,000 young girls in Borno State. So I know it, what teenage pregnancy can do. Women who carry pregnancy after the age of 35 is a high-risk pregnancy. Don't get it twisted. You may look young in your face, but internally you're 35. And the changes that take place in every human being after the age of 35 may manifest or will be accentuated in the process of pregnancy. Parity. Parity means your pregnancy or your gravidity. Let me say your gravidity. Let's use the word gravidity. That means women carrying pregnancy for the first time and women who have delivered their 5th baby and they are carrying their 6th child. The two of you are the same. Your complications are not a joke. The woman carrying pregnancy for the first time is naive, is a novice, and so one of the things we know we should look out for is called hypertensive disorder of pregnancy. We'll look out for it. The one that has delivered 5 times behave as if she's a professional. She's a champion. I've done it before, and I can do it again. What height? Women who are less than 150 centimeters tall, and women who start pregnancy with a weight of less than 50 kilograms, or those who started pregnancy with a weight of above 80 kilograms, or women who gain more than 18 kilograms during pregnancy, high risk. Past surgical history. If you've had a cesarean section, not a problem. But if you have had a fibroid surgery, or worst case, you've had excision of adenomyotic tissue, it's a high-risk pregnancy. Somebody may say, why is cesarean section not a problem, but fibroid is a problem? The difference is this. When you do a cesarean section, you put one incision on the uterus, on the lowest part where there are not many muscles. But when you're doing fibroid surgery, you are putting incisions everywhere. One fibroid surgery is equal to 7 cesarean sections. That's how tough it is. So you cannot say you have a fibroid surgery and you will attempt to want to have a vaginal delivery. You're playing with death. If you have coexisting medical condition like hypertension, thyroid disease, you are a high-risk patient. Those of you who are carrying more than 1 baby, every woman should carry 1 baby at a time. But if you are carrying twins, triplets, quadruplets, high risk. We celebrate it. We know how to handle them. We take care of them because we know that it's a moment of celebration. So, high-risk pregnancy, but we are prepared for action. We are prepared for your safety. There are women who have coexisting gynecological diseases like uterine fibroids. It does put your pregnancy as high risk. Those of you on antihypertensives, many of you seated here are on tocolytics called salbutamol. Salbutamol is a drug that we use to reduce the chances of you having a uterine contraction. We tail it off before you deliver. Just like it's preventing you from contracting during pregnancy, it will also prevent you from contracting after delivery. Therefore, if we don't tail it down properly, you may bleed after delivery. Distinguished students, categorization of patients into high risk and low risk, the variables pre-existing medical condition like hypertension. A woman started pregnancy as a diabetic, has a thyroid disease, has autoimmune disorder, has a bleeding disorder, she's a sickler, she has retroviral HIV, she's an Rh negative mother, she's hepatitis B positive. That's high risk. What about the state of the placenta? Those who have low-lying placenta, either because that's how the placenta just behaved, or because you are carrying multiple pregnancy, placenta found its way low, it's a high-risk pregnancy because you can bleed torrentially from there. Women with previous obstetric conditions like premature delivery, premature rupture of membrane, premature separation of the placenta, you have previously delivered a baby that has low birth weight or abnormal baby, we take a close look at you because you can do it again. A lot of you seated here got pregnant through in vitro fertilization, embryo transfer. Why is the IVF pregnancy a high-risk pregnancy? The reason is because we put you on estrogen until about the 13th or 14th week of pregnancy. Secondly, we use progesterone to support your pregnancy until about 12 weeks of pregnancy. Estrogen. Pregnancy is a diabetogenic state. Pregnancy is a thromboembolic phenomenon. It's a thrombotic phenomenon. In other words, your blood can clot while you are pregnant, even if you don't take drugs. Now you took estrogen. You took additional progesterone. What it does, it accentuates that thrombotic phenomenon. Now, present obstetric state, there are many of you here who have cervical cerclage. You cannot have cervical cerclage and be jumping from one plane to the other. You can't do that because the neck of the womb has been tied. If you contract while on your way to any part of this world, they're going to look for the nearest place to drop you, or else you're going to tear that uterus. Now, I want to ask a question, distinguished students, and let me see if you can answer. Equipment, information, education, clinical personnel, medications, infrastructure, and rapid response. Which one is more important? Which one? Which one do you want to give premium to? I ask again. Equipments, information, education, clinical personnel, medications, infrastructure, and rapid response. The nation that can answer this question, which is more important, is the 5.6 million tiny nation of Norway. They're the ones that can tell us the answer. The answer is information and education. Duration, let me talk now about duration of pregnancy. Pregnancy is for 266 days. But for the purpose of us having a universal rule of calculation, we say pregnancy is for 280 days. 280 days is equal to 10 lunar months. A lunar month is 28 days. But there are many months that are not 28 days. So pregnancy is for 280 days, which is equal to 10 lunar months, which is equal to 9 calendar months. So, if we want to calculate, how then do we calculate expected date of delivery? If your last menses was on the 1st of January, 2025, we will add 7 to the date, to the day. We will add 9 to the month. So that automatically becomes 8th of October, 2025, as your expected date of delivery. If your menstrual cycle is for 28 days. If your menstrual cycle is more than 28 days, we will add the extra days to that expected date of delivery. For example, if your cycle length is 31 days, instead of delivering on the 8th of October, we add 3 more days. It becomes 11th of October. That's just how we calculate it. Expected date of delivery. But for those of you who got pregnant through in vitro fertilization, we know the exact date you got pregnant. It was the date we did the embryo transfer. From that day, we calculate 266 days, and we can tell you the exact date you will deliver, irrespective of your cycle length. Now, to help us manage pregnancy very well, we divide pregnancies into trimesters. The first trimester is the first 13 weeks of pregnancy. Because during that period, you do not have a placenta. No. So anything you eat goes straight from you to the baby. First trimester, that is when women lose weight because of hyperemesis. The first trimester of pregnancy, for those of you who are getting pregnant for the first time, that's the first time you will be getting to understand how your body performs. The second trimester will end at the 28th week, and the third trimester is from the 28th week to delivery. Now, pregnancy is for 40 weeks, but we will give you 2 extra weeks. After 2 extra weeks, we say your pregnancy is going postpartum. In this hospital, we will not give you 2 weeks extra. The best we can do for you is 10 days. Because the placenta has a lifespan. After the 40th week, it begins to degenerate. The next time you will know your placenta is no longer holding your baby is that your baby is dead. Why would we allow that in this day and age? Distinguished students, I want to teach you how to know a good antenatal service provider. Some of you may not necessarily continue here. You may want to deliver in Canada, or because of today's lecture, you get a Schengen visa to head to Norway. But when you get there, I want to teach you how to know a good antenatal service provider. You don't patronize a hospital because it is owned by your brother or it's owned by a club member. A good antenatal service provider, a hospital that can guarantee that a woman will not die, must have a functional operating theater. Number two, you must have a blood bank, because bleeding during pregnancy, during delivery, and after delivery is the leading cause of maternal death. So if I have a blood bank that is working, I don't have a challenge. I give blood for blood. In this hospital, if we need, as we are seated here now, if we need 20 pints of blood to give to a patient, 20 pints of blood we will get. From where? We have our staff who will get it. They all know. You only need to just press the alarm bell. They will all gravitate towards the blood bank. That is part of the power of our corporate image. There must, for you to say a hospital is good for antenatal, it must have ready availability of trained and skilled clinical personnel in obstetrics and midwifery. I did not just say midwifery, I said in obstetrics. How do you, distinguished student, go to a hospital? Don't allow your relation, don't allow your niece, don't allow anybody you know, go to a hospital that does not have an obstetrician who has what it takes to remove the uterus in the day of trouble. That's just how it is. You must have availability of a pediatric team skilled in neonatal resuscitation. Those days have passed. When you deliver a baby, you turn the baby upside down and you begin to spank the baby for the baby to cry. I know they spanked me that way. I survived by the grace of God. And some of you seated here, they spanked you too. The babies that are born now, we don't spank them. We rub their back and say, hey, baby, cry. Baby, just cry, you know. And they cry. You must have an anesthetic team, because women think they are strong until they are in the second stage of labor or they are 7 cm dilated. They begin to shout. You must have a team that can give you a pain relief. For you to say a hospital is good, that hospital must have an ambulance, not the one they will push on the day of trouble. And you must have the ability to do a speedy referral. Distinguished students, if any of you seated here has a challenge at home at 2 a.m. and nobody is there to help you, your spouse has traveled, just take a phone, make a phone call, and call the DMC's helpline. Can you give us that helpline? Is it available? Just put that helpline, and I want you to take note of it. You might be in a situation where you cannot just drive out because of the nature of the place. We will come to your rescue. So, put the helpline for them on screen. I want to urge you, distinguished students, that let's make our country a better place to live in, so that during your birthdays, your anniversaries, rather than throw elaborate parties, call us to come and run an antenatal awareness program in your community and sphere of influence. How do you know a good antenatal clinic? It must have ultrasound scan machines. It must have a pediatric domiciliary service. It must be able to provide postpartum contraception services that hospital must have an intensive care unit. A hospital without an intensive care unit, to the best of my knowledge, I will call that a glorified primary health center. How long do antenatal services last? What is the duration? We expect you to report pregnancy as early as 6 weeks, and you should continue antenatal services 6 weeks thereafter. You must see us at least 8 times during pregnancy. So what are you going to expect when you come to DMC antenatal services from Monday? Well, we promise that we will deliver premium antenatal care services. It will be patient-centered. We will take your history, physical examination. We will do ultrasound scanning, and we'll do laboratory investigations. In this hospital, every antenatal service day is a scan session. For those of you who are going to deliver in the United States, you are going to observe that you are entitled to only 2 scan sessions. You know why? The obstetrician did not take a training in ultrasonography. We took a training in ultrasonography. We can scan for Africa. Now, what do you expect? It will be a booked appointment system, and we'll attend to you very promptly. I hope nobody seated here spends more than 15 minutes waiting to see a doctor. If you have ever come to this hospital and you spend more than 15 minutes before you saw your doctor, just do your hand like this. Wow. Head nurse, are you saying it? He said that she came late for her appointment, or the doctor was in the theater. Let me tell you, distinguished students, there is a kind of alarm that will take place here now. Let me give you an example. On the left side of this hall, there is a box that contains an AED, an automated electronic defibrillator. If you open that box, that alarm will sound in this hospital, here. It will sound in my office. It will sound at another hall. It will sound in the A&E. This lecture will stop. All of us will go. Because whatever makes us require an AED means that somebody is in danger. We all pause. All clinics stop. It can happen. So sometimes please understand that we are faced with some challenges. Now, from Monday, expect us to use electronics to check your vital signs. At each antenatal visit, we must take your weight. It is important for you to give us your urine to test. We will give you medications. We will we'll give you malaria and tetanus prophylaxis. We will inform you through this kind of antenatal class. We will have, on the day of delivery, you have a private delivery suite. What that means is we expect your husband to be at the delivery suite. Even if you are going to be in the theater, we expect your husband, we expect somebody to hold your hand and be talking to you while surgery is going on or while delivery is going on. I want you to expect high-level delivery on the day of delivery. You're going to see what they call obstetricians and midwives and pediatricians. You are not alone. Somebody is keeping a watch over you. We are out there for you. No baby comes out delivered in this hospital without a pediatrician there to resuscitate the child. We will give you immunization services. I think I've spoken so much, and I think you've taken notes. Let's see the helpline. Give us the helpline again, and make sure you take this in case you need our help. And so this is DMC's helplines. Head nurse, is this our helpline? Okay. Well, this is how I'm trained. I'm trained not to believe. I'm trained to be a doubting Thomas. Makes sense. Let's test. Let's test. So, Hilda, please come. I suppose somebody, if it's not working, let's know it's not working and let's solve it now. You're going to make a call to any of this number. I'm sure they don't know your voice, and tell them you are in trouble, that you are bleeding. You need help. Put it on speaker. Let's see. If it's not working, it's not working. Let's solve it. I hope you guys understand. Let's test it. If it's not working, it's not working. Or this is the kind that will say that the phone cannot be reached. Give her a microphone. Head nurse, where is this number? Is it the front desk? Front desk. Okay.
Hi, good afternoon. Okay, my name is Annie, and I'm calling because I have an emergency right now, and I need prompt rapid response in my house. I stay around Preventive.
What's the time now? It's 12:24. No. Oh. They're not supposed to know we are here. Yes, so you're going to put off. It's 12:24. You are bleeding. My children schooled in America. So one day, there was smoke alarm. I don't know what they were frying. Within 7 minutes, fire brigade were there in the house. So let's say, how many hours it will take? You know you are still bleeding now as we are waiting for ambulance. By this time, your husband is going to take phone now and say, please, 5 minutes has passed. Who is going to act as the husband? John Akigbe, come. Or you just tell him, you know that when you are bleeding, 1 minute is like 5 minutes because the man has never seen. Okay. Thank you. I think what you should do now, before they go and land in, where do you tell them you are in? Tell them you are in Guaripa. Tell them, the problem is that I don't want them to, I think they should keep going. What do you guys think? Should we call them back? I think they should come back.
Yes, they should come back. They're already going. You can hear the sirens.
So we should call them back.
Yes.
Wait, let them get to junction first. Wait, let them waste small fuel. Wait, we'll call them back. The next lecture, there will be first musical group come. I've talked to these women. There is this song called Sweet Mother that I want to sing with all of you. That on the day of delivery, we will sing it with you. You will go home with your babies, and when you are going home with your babies, we will sing them with you too. Okay? We'll sing it with you. The next lecture will be delivered by the Department of Pediatrics. It is titled, How to Handle Babies Post-Delivery. We want to touch, this time we want to teach the fathers how to bath the baby, how to clothe the baby. You know some fathers cannot hold baby. So we're going to teach fathers how to bath baby, how to hold baby, how to clothe baby. You know, most babies, when they are giving birth to them, they will turn them upside down and shake them. They will throw them up and catch them so that they will not be afraid of height. They will mold their head, mold their nose. I believe some of you here have bought dusting powder. You have bought mentholatum. You have even gotten your baby box ready and full of camphor. We're going to teach you that those are the things that cause neonatal jaundice. So, you're going to come with your husband, you come with your mother-in-law, you come with your mother next visit, so that we can teach them, because no woman here can tell the mother-in-law not to mold the baby's head or put mentholatum in the anus, because this is how they brought your husband up. Just before Ebony Wave does their sweet mother, in conclusion, distinguished students, you cannot change what a people do until you change what they know. So the real difference between people is the information they internalize in their minds. I don't know, please call the rapid response back. Tell them that the bleeding has stopped and that your husband is bringing you already. You understand? Good. The value you place on your life determines where you seek antenatal care. Trust me. Trust us. Husbands, relations, and those of you watching on screen, leave your wives and leave your aunties and leave your mothers with us. I guarantee you, we will return them back to you safe, hale, and hearty. But I urge you to also pay your bills. When I take your delivery, you pay for 40 years of clinical experience. When I provide you antenatal, you pay for 40 years of medical practice. We practice medicine here with a lot of contentment and joy. I am aware that some of you seated here today are captains of industry, you're high flyers, you're heads of government parastatals. You are great in your own right. And so, I want to send you out today to please join me blow the trumpet on the mountains, upon the hills, and everywhere, that in this day and age, no woman should give up her life because she is giving birth to a life. I send you out as beacons of hope. I send you out as vanguards of truth, as pillars of strength, and as torchbearers, so that where duty calls, let courage rise with danger and strength to strength oppose. May the inspiration of this tremendous hour that I've spent with you linger on our minds to inspire and spur us to change the narratives that will make our world and the land of my birth a better place to live in. I want to thank you for your rapt attention. Sweet mother.